The information shared on the Allo podcast is not intended as medical advice. Your medical care decisions should be made in consultation with your physician who is familiar with your specific case. Hi, welcome to the Allo podcast from the Allo Hope Foundation. I'm Molly Sherwood.
And I'm Bethany Weathersby.
And I'm Katie Shanahan, joining Bethany and Molly today as co-host, best friend, and fellow Allo mom. And I'm so excited to be here. I've had extreme FOMO this season.
Yay! I'm so glad you're
we
here.
needed it too. Yes,
Yeah.
It's not right if it's not the three of us. And just for everyone's comfort, I hope everyone is assured that any inappropriate thing Bethany and I have ever bantered about has also been discussed off camera with you, Katie, in our daily chit chat. So we're just going to carry on, just being our usual selves and talking about things that we shouldn't talk about on a public podcast.
And things that we should talk about too. It's going to be a nice mix.
But also things we should.
Yeah.
And also, as a reminder for who Katie is, Katie's the Director of Development for the Allo Hope Foundation, and she's also an allo-immunized mom with anti-D and anti-C antibodies. And she shared her story about her severely affected pregnancy with her son Liam in season 2 of the podcast. It was episode 3. So please give that a listen to get to know Katie and her story. And also, she does such a great job explaining things and being an educator in her episode especially, which is actually makes sense because you're actually the only one of the three of us who's a clinician.
Right. She did. She used to be a pediatric nurse practitioner for over 10 years before joining us. So that's amazing.
It was pediatrics, though, not OBGYN, so...
Still, you can talk the talk.
You also forgot the most important thing, that I am also a fellow hotel room cuddler. I also prefer to share a hotel room with you both, and I'm just hoping I can live up to everything that's the Bethany and Molly show.
Yes. And also you were with Molly when you experienced my tomb fart.
You just did that. You did that to yourself. I wasn't going to bring it up.
The cuddling in the hotel room reminded me of that little tidbit. So, isn't that what you called it, Molly?
I did call it a fart tomb.
Yeah. Okay.
Because that's what it was.
Yeah,
that was
Katie
accurate.
got it pretty bad that day. So anyway, but today might be one of my favorite episodes so far because not only do we get to be together and hang out, but we get to kind of travel the world in a way and see this Allo HDFN landscape through the eyes of Allo patients around the world. And listeners and viewers, you're coming with us too. So we're going to look at alloimmunization and HDFN treatment, care access, and patient experiences from different regions of the world.
Okay, so we have done a couple episodes in season 1 and season 2 of the Allo podcast that have a more international focus. If our followers want to go back and listen to those after this, I think it's episode 12 of season 2. We talk about vital treatments and cutting-edge research from around the world. That's a really good one with Dr. Ken Moise. And you can also go back to season 1 and listen to episode 14, The Past, Present, and Future of HDFN. And also Agna's interview episode from Lithuania was a really great insight into how a country's culture and even religious influence can affect treatment options and the way that a condition is even discussed. That was episode 10 of last season, season 2.
Yeah, I loved both of those episodes too. So today we want to look at care access and treatment options in other countries, like we said earlier, and kind of broaden our perspective by hearing patient experiences. And stepping back, if we look at patient care and treatment for alloimmunization and HDFN as a whole, we can see some, let me say that again, sorry. We can see some major pillars of disease management, and I think that these would probably be prevention, diagnosis, monitoring, treatment, and maternal support.
We have I like that. We have pillars.
Yeah. Yeah. I'm seeing pillars, and you know how I think in like pictures or scenarios. So when I think about disease management and patient care, I imagine this healthy mother and her healthy baby way up high, standing firmly on this platform. And of course, because I have 4 boys, my mind automatically goes to the floor is lava. All right. So
yes,
the floor is lava, and the mom and baby are totally safe up there on their platform. It's held up by these pillars: prevention, diagnosis, monitoring, treatment, and maternal support. And if one or more of these pillars starts crumbling or gets some cracks or is non-existent, which is the case for some areas, then the mother and baby are at risk of falling, obviously. So today we are kind of hypothetically traveling around the world, and we're going to be peeking in at different countries to see what do those pillars look like in this area or this country or this continent, actually. And hopefully we can get a better view of disease management and patient care all over the world.
I love that analogy, Bethany. The educator in you really comes out when you have to explain things like on a very simple level. But
yes, I got that simple mind.
No, it's so good.
I'm just kidding.
I text you all the time on ways to like educate my toddler about things.
I know, exactly.
Talk to us like we're babies, please.
I do love breaking down complex ideas into like digestible pieces of information. I do love doing that.
Yeah, it's so good. And I'm all about the prevention pillar. We all know this. I feel
yes,
like
we do. Yes.
I talk about
it's so
immunoglobulin nonstop. So that's also called the anti-D injection or ROGAM. I'll probably just refer to it as ROGAM throughout the podcast just for simplicity. But prevention is one of the most important things in this whole equation. And I feel like if we can limit how many moms become sensitized in the first place, that would be incredible. Like that would just eliminate a lot of the disease. So you both know I didn't receive prevention when I needed it, and our family had severe consequences because of that. So just imagine this being the norm in other places that also don't have the right care. It's just devastating. Okay, but before I get way too far down this rabbit hole, we're actually going to have a full episode just dedicated to disease prevention and Rh immune globulin. So I'm going to try my hardest not to focus on that too much today.
In this episode, we'll try to give glimpses of care from each continent and share some patient stories from our patient community. And then we'll go over some key sort of improvements and practices that we can learn from each other. And also, I feel like something we should point out is just because we talk about one publication from a country or one patient story from a country, that doesn't mean that the entire country's practice is like that. I mean, that's even true in the US, where we see such a variation in the quality of care. So I don't want to imply that by us sharing just bits and pieces here, we're making a generality about the whole country or continent, but it's still super helpful for us to have this awareness and sort of diversify our understanding of what this looks like throughout the world. Okay, well, I guess I'll just kick us off.
Yeah, let's begin our world tour.
Wait, before you do
World
that,
tour.
really quick, can I just add one little thing to what you just said?
Yes.
That's such a good reminder, Molly. I'm really glad you said that. And also something that we've noticed throughout this whole process is that there is such a wide variety and a wide disparity, even in each country, of care quality, care access. And so just wanted to point that out, that in every single country, you kind of don't know what you're going to get, unfortunately. So, yeah. Okay,
so let's start with Europe. I have some really good tidbits about a few European countries, and I started to write this by saying we're not going to harp too much on the Netherlands since we talk about them all the time, but I'm actually going to start by talking about them because I couldn't help myself.
We love them.
We love them. I'm trying not to be too crazy, but one thing that they do that is awesome is on the prevention side of things. So not only do they have consistent access to ROGAM or Rh immune globulin, like Katie was mentioning, but some people develop antibodies during a blood transfusion because antibodies can develop during exposure to foreign blood. So it could be through a pregnancy or through a blood transfusion. So it's super common, when possible, to make sure that it's called cross-matching, where it means that you don't give anyone who's negative for the D antigen or has a negative blood type any blood that is positive for the D antigen or has a positive blood type. But you know what? A lot of people develop antibodies if they're transfused with blood that's not cross-matched for other antigens, like Kell, C, and E are really popular. And in the US, we don't cross-match for those antigens before we transfuse somebody. And that's why we all have met moms in our community who are sensitized from transfusion. I think Kell is probably the most common one that we see, which is such a shame because it also imposes extremely severe disease. So in the Netherlands and in other European countries and Canada, they cross-match for these, not only for D, but C and E and Kell. And even our friends in the Netherlands won an award for the best article in 2021 in the journal Transfusion for effectively doing this and reducing Kell sensitization in their country. So we can link to that, which is so awesome. Maybe one day for us.
Responding to what Molly just said about the Netherlands and their screening for Kell, my husband is actually, he's O negative, but he does not donate blood, even though he desperately wants to, because he's also Kell antigen positive. And he knows that his blood is not going to be screened for that. And then at least 91% of the recipients of that donor blood or plasma, no, it's not plasma. Sorry, let me say that. 91% of that donor blood could sensitize the recipient. And so that's just scary, especially because, you know, after what we went through with Kell, he's just like, I'm not doing it. I'm not risking it.
I get it, but it's a shame considering the critical blood shortage that we have, you know,
especially for O negative too.
I know. I don't know if that's the right choice, but he's just like, I can't stop thinking about 91%. Like, what's he going to be doing to families? I don't know. Anyway, we need to bring that over to the US.
Yes, we do.
And also the Netherlands is where Sanquin Laboratories is. And they, until recently, they were one of the few laboratories that could do cell-free fetal DNA testing to determine the baby's antigen status. And I actually benefited from that with my last two pregnancies. It was in 2017 and 2020. And my MFM sent my blood sample over to Sanquin Labs in the Netherlands. They tested it. They got back to me within a week and said, your baby's Kell antigen positive. And that was at like 14 weeks. It was just so nice to know his antigen status early and not in an invasive way. I didn't have to do an amnio. So I am so grateful for these people all the way over on the other side of the world who are willing to test my blood to help me out over here in the US. And also another thing that I love about them, when Katie and I were in Kenya earlier this year, Sanquin also ran extensive blood sampling on 30 Kenyan women for free to help us figure out if they had red cell antibodies, because diagnosis of red cell antibodies is so difficult in that country. And this group of doctors in Leiden, they really care about this disease. They really care about patients, and not just patients in their own country, but globally. And we see that in their work, and we appreciate them so much.
They are wonderful and great models for what treatment can be globally. And they also do great things in the treatment of HDFN that we've discussed before, of course. But some of our favorites are the fact that they have a centralized referral center for all alloimmunized pregnancies in the country, which in larger countries is challenging, but at least centralized referral would be huge to implement worldwide. They have highly trained MFMs conduct the IUTs who do them quite often. They did their own research on IUT techniques and what aspects of transfusion posed more risk of complications, which many people lean on those publications in developing their own IUT techniques. They do weekly MCA scans, which we love. Sometimes they even do weekly titers.
Wow.
And I know. And once the baby is born, they are on it. Those babies go immediately under lights at birth with almost no exception. And you know what else? They put them under light therapy for their high bilirubin with no clothes on, not even a diaper.
Oh my gosh.
They are just
like,
which is quite...
It sounds like a little risky, but
Messy.
also it makes so much sense. Why are we not doing that? Because you know that diaper covers like half of that baby's body.
And they're so aggressive with the phototherapy in that doing it that way that they have really reduced their rate of exchange transfusion in babies in the neonatal period. So anyway, yeah, love them.
Okay, so now I would like to share a patient story from Europe. And like we've done in other episodes, we asked patients for their feedback and we gave them prompts. And this one was for patients outside of the US to share their experiences with alloimmunization and HDFN. And this is Carrie's story from Scotland. So I'll just read it verbatim. So she says, with my first affected pregnancy, I found out about my diagnosis following my pregnancy booking blood tests by receiving a card through the post from the blood transfusion service in the UK. It just said that I have anti-Kell antibodies and that these may affect my baby.
Wow. That's so interesting. So she found out about her antibodies by receiving a card in the mail? Yeah, I'm not sure we've ever heard of that before. It's pretty unique.
It is. I wonder how that would feel. She's like, what is this?
Yeah, it seems very detached or something.
Yeah, then you can't ask all of your many questions. But I guess it's better than not finding out, which also happens, at least over here sometimes. Okay, so back to Carrie's story, picking up after she received this diagnosis news in the mail. She says, I then called my community midwife who advised me that I would be referred to an obstetrician who would oversee my care. I was informed by the OB that there was a risk of baby becoming anemic and that I would be scanned every 2 weeks to measure the rate of blood flow through my baby's brain. So, okay, end quote. So she's having MCA scans every 2 weeks, and I'm curious what her titer was. She doesn't share what it was, but I'm just wondering what it was.
Okay, let's see. I have it in front of me too for the rest of her story. Okay. She says, well, not the titer, but more info. She says, all went well until 27 weeks when the rate of flow was elevated. So she must mean that she was having high MOMs on her MCA scans. She says, I was informed I would have to go to a specialist fetal medicine hospital 4 hours away for assessment and probably IUT, but that they would call me and let me know the plan. When they called, they informed me that I would have to wait 4 days to be seen as there was a fetal medicine conference on for 2 days, and then it would be a weekend. I did not have any understanding of how serious this could be.
That's so sad. She had a high MOM, and then she was told she had to wait 4 days before even being seen by an MFM. I can't even imagine.
That's so terrible. And I mean, the irony that part of the delay was because of a fetal medicine conference. Like, that is just terrible.
Plus the weekend, it just seems like very unlucky. We see that a lot in the U.S. too. Monitoring and treatment is delayed because of the weekend or a holiday. But anemia can develop so quickly and go from slightly concerning to life-threatening in a matter of days. It did that with my son, and I know it did it with your son too, Bethany.
Yeah, in 6 days it went from totally fine to he needs a blood transfusion right now.
Perfect example for weekly MCAs.
Yes. Yeah. So the treatment of hemolytic fetal anemia, it is so time sensitive. And I do wish that overall, in all parts of the world, more people understood that. And like Carrie said, she had no idea how serious this could be because this is a totally new diagnosis for her. Plus, she's the patient. She is not the trained medical professional. And so how could she know? There's no way she could know. And that's just so hard. So, okay, Molly, what happens next?
Okay, so she had to wait her 4 days to be seen on a Monday. This is already after her MCAs are spaced every 2 weeks. But then she goes on to say, by Sunday, I was experiencing severely reduced fetal movements and baby was showing signs of high drops. I went to the specialist hospital on the Sunday evening and received an IUT on Monday. They had put blood into baby's stomach and baby was doing okay. So on Tuesday, I was discharged and asked to wait for further instruction. Unfortunately, by Wednesday morning, I had no fetal movement at all. And on presenting at my local hospital, it was confirmed that my baby had died.
Heartbreaking.
Right. Yeah. And I love the information she shared about her sort of experience and response to this. She says, I felt severely let down by the fetal medicine hospital. My own obstetrician was also upset and had said that if she had understood the severity, that she would have sent me further afield to fetal medicine in England. It was a horrible time, and following this, I searched for answers. I found a doctor who had published research into anti-Kell and HDFN in my husband's home country, so we flew there for a consultation, and he helped me understand more. She said, prior to getting pregnant again, I researched lots, and I wrote the fetal medicine hospital asking them for a plan for treatment if I was to get pregnant again. And she says she had not found the foundation by then. She says she felt very alone.
Wow. That's so heartbreaking. I have so much respect for Carrie and all the other Allo moms who have to self-educate and research and know how to advocate for future pregnancies. It's just so burdensome on these mothers, and they're just so resilient and inspiring.
Yeah. Sorry, can I just respond to that? I'm breaking the script, but that's amazing that they flew to another country and had a consultation there and learned more about the disease. And then before she got pregnant again, she did all of this research, and she wrote to the fetal medicine hospital asking them for a plan for treatment and just getting everything set up. Like, that's incredible.
So amazing.
That's amazing. Yeah.
She reminds me of Rose a little bit.
Yeah. It's amazing.
Yeah. We asked her what the most challenging part of her experience was and what she wants for other allo-immunized women in her country. And she said the most challenging part was that I had to put my trust for the care of my baby into medical professionals and that my baby's death could have been prevented. She says, I would want every allo-immunized woman to receive all the information they need to be able to advocate for themselves and their babies. And she says, I feel like I let my baby down by not having this knowledge and therefore not being able to advocate for him.
That is such a hard feeling to know in hindsight what you really needed to know during that pregnancy. And also that realization that your baby's death was preventable is, it's just so, it's life altering. It's life altering. And then to know I have to face this disease again if I want to try to grow my family. That's why we are so inspired by these amazing, courageous women. And also that's our desire for all allo moms. And that's at the heart of what we do here at the foundation, for sure.
Yeah. And we asked her too, if she has any advice for other allo-immunized women in her country. And she said, please find out as much as you possibly can about your condition so that you can advocate for your baby. Don't be afraid to ask for what you need. After finding Allo Hope, I learned about IVIG infusions, and even though they are not routinely offered in Scotland, which is interesting, I asked for them and then received them for my little girl. I would not have known to do that if it was not for support and information provided through Allo Hope.
That's amazing.
What an incredible story. That was very educational too. I mean, it's super impactful, but it's a great glimpse into what care is like for her.
Yeah, and she did go on to have a healthy baby girl, by the way. Yeah.
Oh my gosh.
Totally healthy.
That's so wonderful. All right, let's just fly on over.
Let's keep going.
Somewhere else. Let's continue.
Okay, new continent.
How about Asia? How's that sound?
Yes. So we're heading over to Asia. And I think that I've mentioned this before. I'm not sure. But when I got pregnant with my first baby, who is now 15, which is crazy, I was living in South Korea. And I spent most of that pregnancy in Korea. So I had my prenatal care at Asan Medical Center in Seoul, South Korea. And my husband and I moved back here to the U.S. when I was like 7.5 months pregnant. So I did give birth here, but the majority of my prenatal care was in Korea. I love Korea so much. And And I love a lot of other countries in Asia, Thailand, Philippines, Japan, China. All of these are very special countries to me and my husband, Josh, for different reasons. But I have noticed something in our actual Allo Hope patient community throughout my years of doing this work. We just don't see a lot of patients from Asia in our community.
I've noticed that too. I feel like
Yeah.
in my entire time here, I've never seen anyone post saying they were from Asia.
Right.
Which is so interesting.
I know. Makes me a little bit sad, but it also means that I don't know much about what this care actually looks like for allo immunized women in most Asian countries. So just keep that in mind. I'm quite ignorant as I talk about this topic here. So I do know a little bit about the care in China and Korea. So I'll just share what I have learned. My cousin lived in China for several years, and she happens to be Rh negative. So I think she had 2 of her pregnancies over there. But when she was pregnant, she had no access to RhoGAM in China. It is not accessible there. And so she actually had to leave the country. She had to go to, I think it was Taiwan, just to get her RhoGAM shots. And then thankfully she never developed anti-D antibodies. But it was, a lot of effort and a lot of money. And I always think about, well, what if you don't have the means to fly out to another country to get your RhoGAM? So honestly, that has always been a bit surprising to me, just based on the sheer number of people who live in China. And I don't know, I just expected to see that basic prevention accessible there.
Yeah. I mean, we're back to my favorite pillar.
Yeah, right.
Basic care, holding the mother and baby up safely over your floor of lava. But do you guys remember, so China not that long ago had their one-child policy, and I think it was from the late 70s to 2015. And it was originally created by the government because they were fearful of growing overpopulation back in the 70s. And so families were limited to just having one child. And as you know, you don't really develop severe alloimmunization, HDFN, in a first pregnancy. Usually that pregnancy causes the mother to become sensitized, and it's the child that comes next that's affected. So if you're restricted to one child, I guess it would lower the incidence of our disease there.
Yeah, that makes sense. Yeah. And then over time, that one-child policy has evolved to allow more exceptions for rural families to have a second child, or if your first baby was a daughter. Eye roll. Can we just... Oh, all right. Girls are important too, guys. But so by 2015, the policy expanded to allow 2 children. And then more recently, they lifted all restrictions on family size. And now they've actually kind of swung in the opposite direction because they're concerned about population growth. So the government is offering financial incentives for families who have more children. But so even with all of that in place, they still don't offer Rh immune globulin or RhoGAM to the patients who need it. And from what I read online, I did do some research on this. It said that anti-D immunoglobulin or Rh immunoglobulin is not commonly used in China due to challenges in obtaining officially listed products from the market and the stringent requirements for importing commercial products, and that leads to stock shortages. So after the past 2 decades, legal importation has not been possible. So bringing that medication into China, and private hospital channels for access have been restricted. And there's no technical guidelines in China regarding the use of Rh prophylaxis. That's that injection. So, wow.
Yeah.
I wonder.
So like you said,
I was just wondering how many people live in China.
Oh my gosh. Yeah, that's crazy.
Right.
So, okay, so if they are becoming sensitized, maybe more than they used to because they're having more children, do you know much about the diagnosis, monitoring, or treatment, or what's our last pillar, maternal support in China?
I actually have no ideas about those areas of care. yeah, if you are an allo-immunized mother who has received care in China, please contact us. Let us know.
Yes.
We want to learn from you.
Yes.
Yeah. Okay, so quickly moving on to South Korea. 사랑해요, 대한민국. I love you, Korea, for real.
Aww.
I love you. There isn't much research out there on HDFN in South Korea, but Molly did find a study from 2019 on the prevalence of red cell antibodies in pregnant Korean women and neonatal outcomes. So this was super interesting. According to the study, the prevalence of red cell antibodies among pregnant Korean women was 2.78%. The most common significant antibodies were anti-D and anti-E combined with anti-little c. The fetal death rate was higher in allo-immunized pregnant women than those without allo-immunization. In Korea, the tests for Rh typing and phenotyping for other major antigen systems were not performed routinely. This is what it says in that study.
Wow.
Therefore, the actual prevalence of HDFN could not be determined and a prospective multi-center study with a complete examination of the mothers and neonates is needed. So that was as recent as 2019. And if I'm looking back at my own pregnancy in Korea, I'm like 99.9% sure that I did not receive an antibody screen in my first trimester. But that was, again, 15 years ago, so maybe it's different now. But yes, again, if you are an allo-immunized mother in Korea, we would love to hear about your experience and learn from you.
Yes, please educate us. That would be awesome. We do need to learn more. We really do need to learn more about that.
Yeah.
I do have one other country that we can touch on before moving on to another continent. And I found a study looking at complications of IUTs in Saudi Arabia. So they reviewed the records for all their mothers who received an IUT for anti-D alloimmunization. And there were 119 moms carrying 154 different pregnancies because they could be pregnant multiple times in the period. And they had 560 intrauterine transfusions total. It's like a lot.
Wow.
So many.
From 154 babies.
Yeah. Isn't that crazy?
Yeah.
So anyway, they, it looks like they reported on complications, which are all the ones you expect, like fetal bradycardia, contractions, bleeding at the puncture site, emergency C-section. And they did report intrauterine fetal death in 8.4% and neonatal death in 5%. And really with all the, in a perfect world, with all the right care, those rates are higher than they need to be. But it is really, really helpful to see what it looks like over there. And I do appreciate them collecting such good data on this. It's always so, so helpful.
Yeah.
We also found another study focusing on IUT outcomes in Iran. And there was some really interesting stuff in this one that we were already nerding out about last night. So this one was a prospective cohort study evaluating pregnancies between 17 to 35 weeks. And this is at the YAS Hospital Perinatology Clinic between 2016 and 2018. And there were 33 alloimmunized pregnancies. Most of the patients had a history of affected pregnancies. And there were 86 IUTs performed in those 33. And the overall survival rate was 75.8%. Which is so much lower than what we're used to. We say our survival rates are like 98%, right?
Yeah.
Because with no intervention alone, it's like 50% survival. So that's like they're intervening and they're only bringing it up another 25%.
Yeah.
But wait,
so
I have a question about that. Sorry. The 50%, are you saying just 50% of allo-immunized mothers who don't have intervention would lose their baby?
I think there's some data out there that estimates that before intervention was available, an antigen positive baby had a 50% chance of survival.
Okay. But all of these babies were referred to this clinic due to fetal anemia.
So they were already sicker.
Yeah.
Than
Well,
that
they
group,
all
possibly.
had, if they're antigen positive, you can still not get anemic, right?
Yeah.
But here, I guess all of them were anemic. So what I'm saying is, if they hadn't received intervention,
Oh,
it
then
would
they
have been
they are
far-
very likely to
yeah,
have died.
They,
Yes,
it would have
I
been
see what you're saying.
far lower than a 50% survival rate for them.
Yeah, yeah,
And so it is heartbreaking to hear that survival rate, 75.8%, but we don't know what resources or conditions they're working in. And so, yeah, considering what would happen to these babies without this intervention, that helps us reframe the 75% survival rate a bit.
So I guess I'll end this portion with a quote from the study that really resonated with me. Despite the proven role of anti-D prophylaxis in decreasing the incidence of hemolytic diseases, maternal isoimmunization still occurs. The unfavorable fetal and neonatal outcomes that were observed in this study could have been avoided by implementing preventative measures, including a good screening program for maternal blood group, red blood cell antibody identification at the time of admission, and administration of anti-D prophylaxis at the appropriate time. I mean, it's just like summarizing what we want to shout from the rooftops on an hourly basis. And going back to your pillars, Bethany, if you have the treatment available but not the prevention and diagnosis and monitoring, then the babies are at risk. And so it just goes to show that every part of disease management and care is so important and is a huge driver for what we're doing here at the foundation, especially globally.
Yeah.
Okay, and taking us to another sobering continent.
Oh, gosh. Here we go. Let's do it. We're traveling the world.
Here for some humility today. Yes.
We're going to Africa, our favorite place.
Oh, we love Africa.
We could spend a whole season on this continent alone, honestly. And I think we're going to do an episode about our trip to Africa, Bethany, right? At some point this season. It's so important to us for so many reasons. We deeply love the continent and the people who live there. Was one of the most transformative experiences of our lives, just going there. And we've developed so many relationships with families and providers in Africa. And Bethany, you actually grew up there too, right?
Yeah. That was my first home. That's my home. So I lived there from age 5 to 8 in Zimbabwe. And then I lived in Johannesburg, South Africa from age 9 to 13. And then I moved back here to Alabama at the most awkward age possible, age 13. So
This is literally, you were literally like Mean Girls. Well, I don't think you were a mean girl, but you were like the redhead who came from Africa. And you're like, what is everybody doing? Yeah. Sorry, I guess I should have just said the name.
All right.
Everyone knows her. Whatever. But I was emphasizing that you are a redhead.
Yes. Yep.
Well, so
That's
when
amazing.
it comes to care for our disease, I think Africa probably needs the most improvement. I mean, I don't know now after hearing about some other
East
continents.
Asia
East
is another
Asia
one that we need to
sounds-
understand more.
Yeah, absolutely.
I think we're just so much more deeply tied to it. It feels like it needs the most attention, but hopefully we'll hear from some Asian patients that can help us better understand. But generally speaking, Africa really does need a lot more attention, and that's why we're dedicating an entire episode to our disease in Africa coming up later in the season. A little teaser.
Yes. So just to like get everyone, get our interest peaked, let's do just a couple patient stories, and then we will have to cut ourselves off from our Africa chat. Otherwise, we'll just carry on forever. Okay, so one Allo mom wrote in about her experience in South Africa and another from Kenya. So let's look at those. And Bethany, I feel like you should share the South African mom since it's one of your home countries.
Okay, so this is from Kayla in South Africa, and this story is actually a bit unique because she's actually still pregnant right now. Well, she is at the time of the recording, so by the time everyone's listening to this, her baby will already be here, and so we'll try to share an update on how everything is going, maybe in the show notes or on social media. So, yeah. Okay, here's what Kayla says. I was diagnosed at 12 weeks pregnant with anti-D, and here we go to an MFM at 12 weeks and 20 weeks for all pregnancies.
Whoa, that's interesting. I have not heard that before.
Right.
Going to like a high risk doctor at 12 and 20 weeks for all pregnancy. I wonder if that's when they have their like routine ultrasounds, like kind of like in the US, we typically have it at those times. So maybe they do those ultrasounds with the MFM.
Yeah. Okay.
The anatomy scan and stuff.
Right, right.
Weeks.
Yeah.
So interesting that the OB probably doesn't do that, I guess.
Yeah.
Okay. Interesting. So Kayla says, I've been having titers monitored every 2 to 3 weeks, even after becoming critical. They were 32 at 12 weeks, and then they dropped down to 16 with a different lab. But then my titer climbed to 256 at 28 weeks pregnant, and I've been receiving polygam since 25 weeks, twice per week, and I haven't delivered as yet. I'm 29 weeks currently. Huh.
Okay, so she's in her 3rd trimester now, super high titer, and she's having polygam. What's polygam?
Mm-hmm. Yeah, I actually looked it up because I was nervous reading her comments because I thought, oh my gosh, is this another brand of Rogam? So I was getting a little nervous about 2 doses of Rogam every week, but actually it's a brand of IVIG, which is used in some cases to delay the onset of fetal anemia. So that is interesting. I've never heard of it being started at 25 weeks. Remember her titer jumped to anyway, into the hundreds. I guess that's when they started it. So, but that is better than having Rogam twice a week. I don't know where I got that idea. So Kayla says the most challenging part of her experience so far is the constant juggle between caring for her family, running her physiotherapy business, and caring for the new baby on the way. She said she feels quite helpless as there's only medical intervention to rely on, and that's really frustrating. And yeah, we can definitely relate to that struggle. We also asked Kayla if she has any advice for other allo-immunized women in South Africa. And she says, I'd recommend forming a team of doctors to support you throughout the pregnancy. My MFM, OBGYN, and the physician administering the polygam have been working very closely together, and it's facilitated the entire treatment. I've also been in contact with the pediatrician that will be looking after Baba. That's cute. She actually said,
Aww.
In contact with the P that will be looking after Baba, and it's great to be on the same page. Wow.
Aw. That is so cool that she's mindful and able to interact with the pediatrician that will be caring for the baby after birth. That is something that I don't think happens very often because we don't talk about that much. I don't think it's very typical to do, but it's so wise. It's a great idea.
Right.
Yeah.
I love that. That's so great.
Yes.
Just seeing that kind of continuity of care. Everyone's communicating with each other. That's like ideal.
Yes.
Yeah.
Okay. Well, thank you, Kayla, for sharing your experience and your advice with us. Okay, we have another patient response, and this one is from our dear friend and colleague, Rose, who lives in Kenya. If anyone hasn't heard her story on the end of season 2 of the podcast, stop what you're doing after you finish this podcast and go listen to that one. Okay, so Katie, do you want to share Rose's experiences with us?
Always.
Yeah.
So we asked, how were you diagnosed? And Rose says, I diagnosed myself.
I love it.
So incredible.
I love it.
After losing my first 2 babies, I tried to find answers from several different hospitals, but they couldn't tell if my babies had HDFN or not. I went online to look for information, ticked all the boxes, and went back to the hospital where I lost my second HDFN baby to find out his DCT test was positive. That really hit the nail on the head for me, and after seeing those results, I was 99% sure that I was sensitized.
Can we just take a moment here and appreciate how incredible it is that she literally diagnosed herself after receiving no feedback from several hospitals, and she was correct in her diagnosis? That's insane. And also, I should add for clarity, the DCT is the direct Coombs test, which is what's commonly run on babies on the cord blood after they're born to see if they have antibodies attaching to their blood. So
That's amazing.
There we go. Yeah.
She's just such an incredible mom.
Yeah.
we asked, what monitoring and treatment did you receive? And she says, I received minimal to no monitoring and treatment with my past 2 alloimmunized pregnancies, and I ended up losing 2 babies. We asked what monitoring and treatment her babies received after birth. And she said, my second HDFN baby was put under light therapy and was going to go through exchange transfusion, but it was too late for that. What was the most challenging part of your experience? What would you want the world to know about the care for alloimmunized women and their babies in your country? This is really hard to read, but the most challenging part of my pregnancy or my experience was losing my babies, only to find out later that they could have been saved. I would want the world to know that the care for alloimmunized women and their babies is not fairly available in my country, for we have a very low number of MFMs and have trouble accessing donor blood, which mainly plays a huge role in saving HDFN babies. And I know we say Max and Alexis's names in Rose's episode, but I just want to speak their names on this episode too. We asked her too if she received anti-D prophylaxis and if Rh immune globulin is accessible to most women in her country, and she did receive anti-D prophylaxis during her first 2 pregnancies, but we're now learning it's not always affordable in their country for average families, and that most women end up missing it due to the high cost. And we'll talk more about that in some of our future episodes, but it's really hard. And she goes on to give advice for other alloimmunized women in her country. And she says to not give up, look up information if you can, learn and join support groups like the AHF support group to learn how to advocate for pregnancies and HDFN babies, and that her 3rd alive and healthy baby is here because of that. And his name is Lucas.
I love it.
He's named after
Lucas.
Bethany's Lucy.
Yes.
Oh my gosh.
He's
gosh.
our miracle baby.
A miracle, the light of our lives.
I know, hard time.
Truly.
Seriously, recently I was printing some family photos to put on the wall, and I printed like 3 of Lucas. Because I'm like, he's part of the family. Thank you, Rose. We love you so much, and thank you for sharing your insights with us. And like we said earlier, we'll share a lot more about African countries in our upcoming episode. So, all right, we're trying to push through here. Let's quickly look at North America. And of course, we talk about the US all the time, so we're going to skip over that one. But we do want to focus a little bit on Canada. And we have a lot of Canadian allo moms in our patient community, which is awesome. And we found a really good study from Canada, Hemolytic Disease of the Fetus and Newborn, Historical and Current State, by Melanie E. Jackson and Jillian M. Baker. And this was super thorough. We don't have time to discuss all the great information in this article, but I did want to quickly highlight a few pieces regarding cell-free fetal DNA. And they say that it is a really good option compared to the amniocentesis because of the risk of fetal loss and even possibility of enhancing antigen exposure and sensitization through that amnio. So that was really good. And then they also talked about IVIG, and they actually considered a titer of 32 as a high titer that would warrant IVIG as a possible treatment to delay the onset.
I've not seen one
of
that
an ED.
low.
Yeah.
For anti-D, at least they say. But yeah, that's so interesting.
Right. And it says that IVIG can be used to reduce the need for invasive fetal monitoring, intrauterine transfusion, and postnatal exchange transfusion, but that using the therapy beyond 16 weeks has not been shown to be effective. And so that kind of tracks, I think, with what we know about it. So super interesting. Antibody titer of 32 or higher for IVIG there. And then they also talk about prevention in high-income countries. So, we were just kind of on the other end of the spectrum where we were talking about how difficult this is in lower-income countries. But if we're looking at high-income countries, they do point out that it's very important to have adequate training and resources and education in these countries, even though, yes, we do have that prevention pillar, for the most part, we have that prevention pillar accessible, and that has greatly reduced the disease burden. But we still need to have vigilant monitoring, and there's this increased trend that they're seeing for Rh negative women to refuse that Rh immunoglobulin, the RhoGAM, because of reluctance and ambivalence about all immunizations. And so they're seeing that the incidence of preventable alloimmunization is increasing again. And that was super concerning to read.
Yeah. We've seen that a little bit too.
Yeah.
It's definitely
I feel like we've
education
been
is
saying
critical.
it, but we haven't actually seen it like in publication before.
Yeah.
Right. Yeah. And then one more thing, that this is not in the study or anything. This is just kind of anecdotal of what I've noticed over the years of patients in other countries and the care that they have access to. But, you know, there's different healthcare systems in different countries, obviously. And in Canada and a lot of other countries around the world, they have that universal healthcare available. Unlike we have here in the U.S., where we have private insurance, right? And we're responsible personally to pay for that. And so I have noticed that there are some really good parts of that universal health care. And there's some downsides too, especially in rare disease where you're not fitting this typical kind of checklist mold of care. And so the basics, the checklist things seem to be very readily available. But then when it comes to rare disease and it comes to patient advocacy, that seems to be a bit harder in those universal healthcare systems, in the public space, that public healthcare. It seems like the patients they don't have quite as much power. And again, I could be wrong, but this is just something that I've noticed. Yeah. If you're from Canada and I'm wrong, please correct me. Let us know. We want to hear from you. Educate us. All right.
All right.
Let's go. Let's go to another
Let's
continent.
do South America.
Let's go. Let's go just straight down.
We don't talk. Let's go down. That's
North
right.
to
Let's
south.
talk
Here we
about.
go.
Yes. Let's talk about Brazil.
Okay.
Okay. We found a retrospective cohort study, meaning like a study that's looking backwards at older medical records. Not older, but previously happened medical records. For their pregnancies requiring IUT between 1991 and 2021. So that's a 30-year span. And 1991, like, unfortunately for all of us to realize, is actually kind of a long time ago. So things do evolve and improve like over time. So we'll see.
Wow, 30 years. I bet so much changed in that 30-year span.
So they did have 388 IUTs in 169 fetuses during that time period. And the survival rate was 79%. They talk about their IUT complications similar to what we see as common complication risks. But they did have a rate of high drops of 35% at the time of first IUT.
Wow.
So 35% of those babies had high drops when they began receiving or having an IUT.
Yeah.
And then 50% of those babies died.
Wow. That's a lot.
That's a lot. So for babies that didn't have high drops at their first IUT, the survival rate was 94.5%, which is obviously noticeably significantly different from babies who started off with high drops. Yeah.
That's incredible. Wow, 94.5 survival rate versus 50% survival rate. And both of these all these babies are anemic, but one has just developed past that kind of threshold of fetal high drops. So, yeah.
It makes you wonder if they just presented late with high drops or they weren't picking it up as quickly or intervening until there were high drops. But like Liam, my son's fetal anemia came on so quickly and he was starting to develop high drops when he had his first IUT. He had abdominal ascites. And thankfully he recovered and is healthy, but I could see how this could happen frequently without really attentive monitoring.
Right.
Right. Yeah. I was just thinking that kind of points to a lack of adequate monitoring. If we're looking again at those pillars of disease management, there we go. That pillar, it needs attention. We got to give some attention to the monitoring pillar. Yeah.
Yeah. I'm also wondering, based on this study, I'm wondering about the care quality in the neonatal period, because they talked about in the 36 deaths to HDFN that they recorded, 14 were during the fetal period and 22 were neonatal. So more after they were born.
Wow.
Which is so devastating, because it's so much easier to treat when they're on the outside. They need a blood transfusion. They need light therapy. It's just really,
What do you think is behind that? I've never.
I don't know. Earlier, maybe that was like 30 years ago, closer to 1991, and care just wasn't as good. And I don't know.
I do wish they stratified this by year, by like.
Yeah, I still feel like back then it would be especially risky for fetal intervention compared to neonatal, right?
Yeah,
because
for sure.
they were still developing the IUT techniques, and that was quite new. But the neonatal management wasn't.
Yeah,
I don't know. Very curious about that.
Yeah, I know. Yeah. We'll have to learn more about that. Maybe there's something to do with access to blood or access to phototherapy that we're not aware of.
Yeah. Okay. Well, thank you for sharing that, Molly. Super interesting. And now let's head on over to our last continent, which is Oceania. I don't even know how to say that. Oceania. And guys, look, I didn't even know that this continent was called Oceania until very recently, when my 6-year-old son Callum educated me. When I was little, we called it Australia, which is like very narrow.
Same.
Oh, you did? Okay. I was like, was this like an African
But my kids have like
thing?
a continent song, and Oceania.
Callum says Oceania.
Well, I will stand by anything that child says.
6-year-old that's smarter than all of us.
Yeah, I will stand by that. So that's
wow. Okay.
But we do have a lot of moms in our group from Australia, so I think we'll focus mainly on Australia. And just like other large countries like Canada and here in the U.S., Australia has a wide variety of care access and quality for alloimmunized mothers. And I think we see it all over the map with women that are posting in the support group and who have submitted their stories. And there are many women in rural areas that have to travel long distances to access specialists that are experienced in the management of HDFN. So in Australia, they have the National Blood Authority, and their guidelines on prevention with Rh immune globulin. It's administered at 28 and 34 weeks of pregnancy and postpartum. And then it's also administered during sensitizing events taking place throughout the entire pregnancy. So it's super interesting that they receive RhoGAM twice during pregnancy and again after delivery. I wonder if that's true for most women. I would love to find out more, and then we can talk about it in our RhoGAM episode.
Yeah.
But I do think their access to RhoGAM down there is a little bit better. They have more of a streamlined process for donors, so maybe that has something to do with it.
Yeah. I'm excited to talk about that in the RhoGAM episode. That's going to be really cool.
Same.
And also that's where RhoGAM started, right? I mean, it was in Australia with the man with the golden arm. I think his name's James, but I can't remember. James
Harrison, right?
Harrison, that's right. Oh my gosh. Yeah,
I'm telling you, I'm like the biggest RhoGAM.
And he's like, Harrison, right? Is that it? She's like, no, it is. She's like, I'm being modest, but it's James Harrison, okay?
Oh my gosh. Oh my gosh. I love it. Okay, so kind of along those lines. Kind of on loins. All right. I actually found the current criteria for clinical use of IVIG in HDFN patients, but the most recent, I guess, bulletin on this was published in 2020. So I don't know how accurate this is, but it's from the Patient Blood Management Guidelines and IG governance. And so this was super interesting. They say that newborns with HDFN, they do not recommend IVIG for those for neonatal treatment of this disease. But prenatally, in maternity patients with a fetus affected by HDFN who's at high risk of early fetal hydrops or death, they do recommend a course of weekly IVIG. So that is, I feel like, flipped from kind of what we usually see.
Right. There's a lot more reluctance, I feel like, to do prenatal IVIG. And then they just, yeah, I agree. That is interesting.
Yeah.
Yeah. Okay, I think it's time for some patient stories from Australia. We had 3 Australian patients share their stories with us, which is amazing. So I'll read the first one. This is Namrata in Australia. She says, I was diagnosed during my pregnancy with Kell antibodies. I had lost my first baby at 21 weeks, and antibodies were detected after that pregnancy. And she says, during my second pregnancy, Kell antibodies were detected, but I didn't receive any treatment during that time. I didn't know about the severity of Kell antibodies because my treating team didn't explain it to me. I was only told that I have it and it can affect babies in future pregnancies. This is why I don't have any treatment plan before planning for the baby. I was referred to the fetal maternal unit, but I lost the baby before my appointment. It was 15 weeks.
So heartbreaking.
It really is. She must have had very
So
aggressive,
sad.
probably high titer Kell antibodies. And in pregnancies like that, well, I feel silly being the one saying this because you've lived it, Bethany, but in situations like that, it is a very precise recipe to bring a living baby
It really is.
through that. Yeah. She says she's now in her 4th pregnancy and she's 28 weeks pregnant. And she says during this pregnancy, the antibodies were detected at 8 weeks. There was no treatment plan at that stage. I was referred to fetal maternal unit for another condition at 15 weeks. They also did the antibody screening and antigen test for my husband, and I was told that the antibodies will not affect the baby until 20 to 28 weeks, and I don't need to worry about it. Literally, where does that come from?
I
That
don't know.
literally,
That's what
someone
we
just
were
pulled that out of thin air.
I don't know.
Yeah.
We were told that as well with Lucy, even though
Where? I
my titer
can't-
was in the thousands with Kell, and they were like, should be fine until, they even said 22 to 24 weeks.
That is where I can't find where anyone decided to hang their hat on that. That's a big bummer. I'm like, where did that come from? Okay. Anyway, so she says, I went back for a scan, though, at 17 weeks, and she already had an MOM of 2.6.
Wow.
That is terribly high. That's so scary high.
That is so scary. Wow, I'm so glad they did that 17-week scan, though.
Yes. So she says she had an IPT, which is an intraperitoneal transfusion into the baby's belly, at 17 weeks and 5 days, and again at 20 weeks. She says, since then, I've had 3 more IUTs, and I'm having MCA scans twice a week.
Wow. It's crazy she went from like being told the antibodies wouldn't affect her until 20 to 28 weeks, and now she's having MCA scans twice a week.
Wow.
But we definitely need an update, Namrata. Like,
Yeah.
we need to reach out to her and see how everyone's doing, and then definitely share an update when the episode airs.
Yes, absolutely. Okay, when we asked her what the most challenging part of her experience was and what she wanted the world to know about care for alloimmunization in Australia, she said, I feel like there's a lack of knowledge about alloimmunization. There is also a gap between awareness about pre-pregnancy treatment planning. I would have never known about IVIG and plasmapheresis if I hadn't found the Allo Hope Foundation. She said, my medical team never mentioned this, which makes me frustrated and sad, and the stress of having intrauterine transfusions is really difficult to cope. She does say the best part of being in Australia is the cost-free treatment at public hospitals. So that is wonderful to not have that financial burden. But that's sort of what you were kind of getting at, Bethany, is the flip side of the centralized healthcare where you can't as easily choose who your doctor is.
Right.
Yeah. Then you wonder what the quality of care is at the public hospital.
Yeah.
Right. Her advice for other allo moms in Australia is reach out to a specialist once you know about your diagnosis. There could be a delay if you just rely on your medical team to reach out to your specialist. And if you know you are alloimmunized before you are pregnant, it would be beneficial to have a consultation before pregnancy to make a plan. Yes, great advice.
Such good advice. Wow. Yeah, that makes me super curious about that universal health care and what it looks like in Australia. And it sounds like there's public care versus private care, but I don't know much about it at all. So,
and Namrata, we're sorry for your losses, but thank you for sharing your experiences and your advice with all of us.
Yes,
for sure.
thank you so much.
Okay, I'll share the next patient story from Australia. This is from Amelia, and she was diagnosed with anti-Big E during her second pregnancy. She tells us, my GP's office called me to come in and see my GP after doing routine blood tests when I found out I was pregnant. During that appointment, she explained the condition and told me she would refer me to an MFM straight away. In Australia, you can go to a public or a private hospital. Interesting. It sounds like you maybe have a choice. But I chose to be referred to a private MFM. So she was referred to a private MFM. I wonder if the cost is much higher for that care, kind of like what we see in Kenya.
Right.
Yeah. I am super curious about that too. Yeah. Okay. Interesting.
So she continues, I saw my MFM from 11 weeks onwards, initially every 3 weeks, then 2 weeks, then every week, and then twice a week during the last weeks of my pregnancy. Wow. I got titers every 2 to 4 weeks, and she tested MOM scores at every appointment. She was induced at 37 and 6 days, and baby M was born positive for anti-Big E, but healthy and happy.
Oh, love it.
I know. He was put on triple lights immediately as a precaution and was on and off lights for the next 2 weeks. Because I was a private patient, M was on lights in my room.
Wow. That's so nice to be able to be near your baby.
I'm so grateful we weren't separated. Oh my gosh.
Wow.
Although that should be available to everyone, but that's incredible. Okay, sorry.
So interesting.
Oh, that gives me goosebumps. Okay. Baby received heel prick tests intermittently after discharge. He was jaundiced and then anemic, but the pediatrician we were seeing was satisfied he would rebound naturally, which he did. I was on edge during the pregnancy, but particularly after birth. I felt like the pediatrician was very experienced in alloimmunized babies and was a bit dismissive of my concerns. Overall, though, I knew exactly what was happening and was coming, and it was generally very smooth.
It sounds like
Interesting. She also said that the most challenging part of her experience dealing with her own anxiety about what could go wrong, but her care was excellent. It's so hard not to go down like the worst case scenario route.
Yeah.
Her advice for other alloimmunized women is to ask for advice on the Facebook page if you are concerned. She has received some excellent Australia-specific advice on there regarding doctors and testings.
Great.
I'm so glad the support group is so helpful for these people that are writing in.
Oh, I love hearing that so much. Thank you so much, Amelia, for sharing that with us. That's great.
And I also want to thank the other patients from Australia who are sharing this really vital information that honestly only you truly understand if you are in that country and understand the care there.
Group.
We can't really speak to that. So thank you for sharing.
Yes. Yeah.
Okay, I will share our last patient story of the day. And I'll just read this one verbatim. My name is Jay. She's going by Jay. I'm 38 years old. I live in Australia. I fell pregnant quite easily with my first child, and after years of trying for a second baby, we went to a fertility specialist, and he had run all the usual blood tests. When I went back for my results, my husband and I were ecstatic to tell him that we had fallen pregnant naturally. That's awesome. During that appointment, he told me they found something in your blood, anti-DIA. I don't know what that is.
Funky one, yes.
Right? Interesting. We left that appointment completely caught off guard, and our elation turned to complete bewilderment. We had no idea what was going on or what it meant. He had given us zero explanation. There was no mention of alloimmunization, RBC antibodies, or HDFN, nothing. He said that I needed to see a hematologist. My appointment was triaged, and I waited weeks to see a hematologist, only to be referred on as he was not comfortable that he had the expertise to take on my case. I was bounced around between hematologists, and it took a while to get answers from them. I did, however, have a wonderful obstetrician and general practitioner who had knowledge of the disease and how to manage it. My OB was able to explain the pregnancy to me and lay out a care plan. I felt comfortable lay out a care plan, and I felt comfortable with this approach. My antibody is uncommon, and I did not have access to the free cell fetal DNA test, right? Because it's only available to certain antibodies. Regardless of my husband's antigen status, they chose to err on the side. Regardless, they chose to err on the side of caution and proceed on the basis that my baby could still be at risk for HDFN and monitor my pregnancy in this way. So I was monitored with regular titer checks. In Australia, the critical titer for antibodies, besides Kell, is 32. I had a starting titer of 8, did eventually reach 16 a couple of times, and requested and underwent MCA scans when that occurred. I had a planned C-section at 37 plus 3. Her son, let's call him O, was immediately taken into the special care nursery at birth. He did have low blood sugar and high bilirubin, which was trending up, and spent some days under lights in an incubator. They monitored his bilirubin closely. He was also under the care of a pediatrician, and they ran his cord blood, and we eventually were given the news that he was Coombs negative, so he wasn't affected.
Oh my gosh.
Oh, but she does say that she says, this diagnosis changed me in many ways. It was very difficult to be thrown into a world you didn't even know existed. I was frightened of the unknown, frightened to think that my body could be harming my unborn baby, and I was frightened of having a blood condition. Having said that, now I am proud of what I went through. I'm proud of this community and all the women navigating this disease, and I'm proud to talk about my diagnosis and to bring awareness to allo-immunized pregnancies and HDFN.
Oh, wow.
I feel like I'm getting emotional.
I know.
We don't
I've never heard of it talked about as being proud. I do feel so proud of this community for like returning the favor to other women by talking about their experiences. It's just so amazing.
Right.
We don't say the word proud enough, but when I heard it, I realized I needed to hear it.
Yeah.
You know?
Yeah. I'm proud of what I went through. Yeah.
Yeah.
Okay, so I think we've covered all the continents and nerded out for enough today. Hopefully people are still with us, but I think it goes without saying that we feel so appreciative for the many things that we used to take for granted, for sure. And we all just want to say to all the women that are navigating this disease on every continent, we see you, we grieve with you, and we hope with you. And we will continue to work hard on your behalf to educate others about this disease and to bring awareness to your plight and to improve treatments, because every woman deserves the right care, and every baby deserves a safe delivery into this world and a healthy life.
Totally. I also want to say that this can feel so overwhelming, thinking about all the improvements that really need to take place in the management of this disease, all those pillars holding up the mom and baby, keeping them safe. It can feel disheartening to think about these regions of the world that need the most improvement, the most attention, but it's also those same regions where the biggest change can take place, even with small, simple changes. And we can really make a huge difference, huge advancements in care access and patient outcomes if we just take on some of these issues together. So, this has been such an enlightening episode for all of us. Thank you so much to the incredible women who shared their stories and experiences with us, and to the many, many physicians, educators, and researchers who have studied this disease all over the world and shared such vital information with all of us. Your work is incredibly important. So thank you so much. Katie, do you want to close this out?
Sure, my first time.
Yay!
Yay!
And okay, I guess since I'm the director of development, it does seem like a perfect time for a plug to remind our listeners that we do rely on donations to make it possible for us to help international patients afford a test that they need, or to purchase Rh immune globulin for women in countries who can't afford it. And this relies completely on generous donations. So we encourage you to visit our link in the show notes to our Donate Now page.
Nice.
Okay. Here we go. I'm so excited.
Oh yeah, I'm
Let's do
excited
it.
for you. Okay, it's like a
I hope I
christening.
can read it, and I know in like one of your voices. Okay.
Do it in your voice.
No, do it your voice.
Please don't
No,
do it
I mean,
in our
but like
voice.
it just sounds so nice when you both do it. And I'm over here like all nasally.
No.
Okay, here we go.
You're good.
Whether you are a patient, provider, or otherwise affected by antibodies in pregnancy, we are here for you. We have great resources on our website at allohopefoundation.org. That's Allo spelled ALLO, hopefoundation.org. Yay.
Nailed it.
Yay.
Love it.
First affected pregnancy, I found out about my diagnosis following my pregnancy. Sorry, that looked like a period. Let me say it again. I've got to clean this computer screen. This is insane. What have my kids been doing over here? All right. Let me say it again. Punctuation matters, guys.